We open now the discussion. We have 10 minutes left, and I invite all the speakers to take a seat behind the table. Yes, in the front row. Sorry. Yeah.
Hello. First of all, I wanted to say how very much I enjoyed all of the presentations. Thank you. And in particular, I wanted to ask Stephanie Wu, has Arizona changed its policy now with regard to the podiatry services being withdrawn?
I'm sorry, I heard something to the effect of the podiatry service being withdrawn.
Have they now been, are they now being provided, given the evidence that you've presented?
Have they reverted or started? They have not yet. I think that eventually they will, but it's something where once they have the legislation in place, it actually takes a long time to go and try to reverse it.
Goodness me. And that
so yes, it's such a pity because they mean so well. They wanted to save money, but they ended up spending more because of the patients who got sick.
Not a surprising consequence, but given that it was 4 years ago and they still haven't changed, that is surprising to me.
Yes.
That Arizona case is a striking example of, as mentioned by Stephanie, but also by in the DFCon meeting last March, that trying to save money, you know, costs much more. And thanks to the group of David Armstrong, Joe Mills, and others, it became apparent that, you know, skipping reimbursement costs, podiatry, you know, means you have huge expenses. Can you imagine $1 saved cost $48 back? So it's an amazing story. And I think it should be an example for many ministries of health. Are there more questions? Nalini, may I ask you, how did your government in the Dominican Republic react on the step-by-step program, Train the Food Trainer course? Did you have cooperation from your government?
Yes, we have, and they are very, very happy because we are giving them a solution. Our government do not have a prevention programs. This is the first prevention program we're going to implement.
And what's your impression in the other countries? Let's say for the SACA region, South American, Central American region. Are the governments also interested?
Yes, they are.
Do you think, you know, this Train the Food Trainer course, what was developed by Christine van Akker and her colleagues, did really change this policy? Because up until 2 years ago, there was no cooperation at all.
We have a cooperation now because we are demonstrating that it's really working. In the hospitals, we divide the department into departments. One department is for prevention and one department are for ulcers. The food that have ulcers, we treat it different. At the first time, the food that have ulcers, there are a lot of people there. Now we can see the people in the other department, in the Department of Prevention. We have 50% with people with ulcers and 50% of people with prevention. So we are creating, we are teaching the people that we are really working, and they are understanding that what we need is prevention.
Thanks. Another question? In the front row, yes. Why not?
I'm sorry. Given the importance of education, but also the cost of education, in your area, do you have many expert patient programs?
How many experts?
Expert patient programs, where patients help to educate each other.
Well, we are, you mean teachers? that we are teaching people?
In the UK, for many long-term conditions, there are expert patient programs where patients with long-term conditions undergo a short period of education
Okay,
to help them
I
educate others.
Okay, the education programs, they are not established an education program for patients. Doctor is the one that is giving the education to the patient. That's a big problem.
But
We start with the nurses. The nurses, we are teaching them, but we don't have like that. It's not organized like that.
I'm just thinking because of the cost of physicians and nurses, and also in terms of efficiency and the maximum number of people you can reach,
Yeah.
whether that idea might be possible in the future.
It is. It is.
Dr. Shigeo Kono, as I said, I was very impressed with your meticulous research data on all these countries. And in fact, I have the same question as I asked to Dr. Campillo. Looking at your work, does that help to convince the local governments to get more attention for diabetic foot care?
Some countries, the government have a great interest in diabetic care, especially in the small countries such as Fiji. Yes, and such as Fiji. And in the case of the government, especially in the developed countries, seems to not to have any interest in the diabetic foot, but rather than other developing countries such as Vietnam and Fiji. And several years ago, when I visited Vietnam, they broadcasted how important the diabetic foot care is by national broadcasting television at 7 p.m. all through the Vietnam. And so I was much surprised that we don't have any such a propaganda from the television, how important the diabetic foot care is. And so some countries, government, especially developing countries government, admits the significance of the preventive diabetic foot care to reduce the medical cost.
Thank you. More questions? It's amazing, Shigeo, that, and sad in a way, that the third largest country, Indonesia, is in a way falling behind. As you know, India and China, they have more than 1 billion people, inhabitants. Indonesia has 600,000, and although we have some representatives there, not much is done there to tackle diabetes, and obviously also to tackle the complications. Do you see any chances for Indonesia to improve their policy?
Oh, I have ever visited Indonesia twice, and I have collaborated with Indonesian doctors, but Indonesian professor of the diabetology showed many data to the government to how important of diabetic foot care. And now Indonesian doctors are gradually setting up diabetic foot care systems in all over Indonesia. Indonesia has many islands inside the countries, and they use the teleconference to promote the knowledge of diabetic foot care.
Thank you. More questions?
I think that that's one issue that we can discuss that we haven't mentioned, because everyone has been so much focused on authorities that you have to pursue your government, etc., etc. But it's one issue that we share with Dr. Wu, because the US statistic, we have the UK statistic, we have the Scandinavian statistic. The interesting point is when we look region by region within countries, we have 4 to 12-fold difference in incidence of diabetes-related amputations. And they can't be explained by differences in comorbidities. So what is the discussion in the US regarding that?
A lot of what people think is attributable to the increased density population in terms of obesity as well as diabetes in the southern region has a lot to do with just their culture and the food that they've grown used to. In the deep south, people drink, instead of iced tea, they drink something called sweet tea. And it's almost therapy sweet. It's extremely, extremely sweet. But that's something that they grew up with, and that's what they eat. They eat a lot of fried foods. They eat a lot of it's things that has very high cholesterol in it, and it's a part of it has to do with the culture, because the United States, if you think about it, it's very large. It takes about 5-6 hours to fly from one end of the country to the other, and even geographically, people eat differently. In the South, they tend to eat the food that they tend to eat, which is why we see people tend to be a lot more obese, a greater chance of density of obesity, and as well as diabetes.
There is one issue in this that I want to raise with you, and that is, in my belief, there is one other key issue. That is the attitudes and the beliefs from your fellow man. That means, do doctors want to treat the diabetic foot, yes or no? Do you love the diabetic foot, yes or no? Because in many cases, you also have a lack of focus and interest in the area of diabetic foot. How many orthopedic surgeons would like to be profiled in the diabetic foot? How many vascular surgeons say, beautiful, I have a diabetic patient, I will have to do revascularization, that takes me double time compared to taking care of non-diabetics. How many diabetologists would love to treat a diabetic foot? I think there's one issue we have to remember, and that is the attitude from our fellow man. And some of the studies we've seen in Europe is actually that the difference also can be explained whether the healthcare system by itself, the nurses, the doctors are actually focused on that. Because we have also been talking about unawareness from the patients. But we have an unawareness and a lack of beliefs and different kind of attitudes among ourselves. And that was the thing I wanted to raise.
I think with these wise words and true words from Professor Alberquist, we come to a close of this session. Madrid was for 1 hour the center of the world with presentations of Asia, North, Central and South America. Congratulations, Javi. You attracted us all. So I'd like to thank the speakers for an excellent presentation, very clearly and very informative. So, and thank you for coming. And I might remember you that we get a lecture at 2:30, an honorary lecture for Christina Lindholm in the next room at 2:30. Thank you very much.